I know we had one in the chat coming up regarding Marfan syndrome, and I don't believe any of the parents here have any experience with children with Marfan's, but that comes up a lot in the office. And Kim or Allison, and you can find their information on our website, are more than happy to answer those questions and have a lot of experience with it, as does Dr. LoSasso. Dr. LoSasso, do you have anything you want to say about that question while other people are coming up with questions?
Absolutely. So first of all, I just want to say all of you parents are truly my heroes. That was so beautifully done, so honest and sincere and giving. And I just want to thank you all for sharing your individual experiences and those of your children. Something I've known since I began doing this work is the difficulty that the decision to consent for a child with regards to this operation. It is a big operation, and there are risks involved. There's no question. But I'm always so humbled by the decisions that you've all made to entrust the care of your children to me and to my team, and the courage and the selflessness that is involved in making that decision, knowing that it is putting your child and yourself and your family, as someone said tonight, in harm's way, but knowing somewhere in your heart and in your mind that this is going to be a life-altering procedure, and that in the end, your child's life will be so much better because of it. But I want to salute you all for the courage that decision required. And believe me when I say it's humbling to know that you entrusted the well-being of your children to me and to my team. We deeply appreciate that. Thank you for your honesty tonight and for supporting so many other families across the country in doing so. So with regards to Marfan's, I would say that it's a rare associated problem. It does not preclude doing a Nuss procedure. There are some special technical considerations that need to be addressed when a patient has both Pectus, excavatum, and Marfan syndrome, but by no means does it rule out a Nuss correction. And as I think I mentioned, Marfan syndrome is always ruled out in the course of doing the workup for the condition. So that's part of the reason why if you have the condition, whether you decide to have it repaired or not, it's important to be fully evaluated so that a connective tissue disorder can be identified, because there are long-term significant implications if that is identified as part of the Pectus syndrome.
Thank you, Dr. LoSasso. If anybody prefers, so we have the directions as to how to raise a hand right now up on the screen. If you prefer to type into chat as well, then we will get to those questions in order also. Nicole Bilardio, you are up next if you would like to ask a question.
Sure, thank you. I guess I have two questions, and the first would be to the parents that were from out of state. I live in Illinois, so obviously I'm in the Midwest, but what was it like flying back home with your child, as far as, just going through airports and the plane? Was that a lot to have your child go through? And then my second question would be, where do you start with getting all these tests? Obviously, if you're out of state, does Dr. LoSasso give you, I know, like you guys said in New Jersey, he has a list of a network of providers, but if you are out of state, how do you know who to go to for an MRI or allergy testing or any other tests that, you have to get prior to getting the surgery?
I'm in Illinois too. Maybe we're neighbors.
Okay.
So they'll help you. I think we have all the testing that you could want here in Chicago.
Okay.
As far
I'm just outside of Illinois. I'm just like an hour outside of Chicago.
The flight home. So we got the bars put in with Dr. LoSasso was still in San Diego, and the flight home. I think we stayed there 2 weeks. Nice, beautiful weather. And I was nervous on the flight home. I mean, I won't deny that it was an ordeal. You're concerned. You can't really help your child because you can't, pick him up, or what if you know. So it's an ordeal. But if I had to do it again, I'd love to. Shouldn't we be able to do it in Chicago? Like I think that's what the California couple said too. Like,
yes, yeah,
be able to do it here. And you don't want to have to do this operation again. So you're going to go to the best, and Dr. LoSasso is the best. So it's worth it. Okay.
Yeah. I had someone kind of say to me, why would you want to go out of state when you live in the Chicagoland area? Because of all the travel, the fact that you have to come prior to surgery, you have to stay after surgery, you have to do follow-up visits. So they kind of were more or less saying, don't choose, an out-of-state doctor.
Yeah, as folks who chose an out-of-state doctor in the middle of COVID to fly from California, and to come back into California, where there was a risk of having to quarantine, I can tell you, I completely agree with what Raquel, I'm sorry if I mispronounced that, said. It's not easy. It's not to come, coming back with Grace. It was just the two of us. And I came back just with Connor as well. And you don't want to be carrying a lot, right? Because you really want to just have all your attention on your son or your daughter. I think the most important thing, and who's great about this is everyone. It's the team. You time that medication such that they're getting the real, the high caliber part of the medication while you're there. I think that's important because timing that was a little tricky. And of course, during COVID, Grace had the face mask, like the two little the face shield and the two masks. And it's a 6 hour flight. Yeah. It's not easy, but it's also it's the least hard thing that kid has done in 2 weeks. So, and you're going home. It's not like you're going someplace that is scary or tough. So I think it's really just, it's harder on the adult, like in terms of like the stress and you're so worried and so concerned. But the kids just know, okay, as soon as I get on this flight, they're not going to be able to sleep, right? It's not that comfortable, but they're going home. So I would not hesitate. We didn't, and that was during the middle of a not so fun time to fly.
Right.
Your second question was really good. You want to talk about your second about the testing?
Oh, so the testing. Yes. So we had that same challenge, if you want to call it that. We really leaned on our pediatrician and kept him appraised of our decision, and he helped refer us to the appropriate folks for the various tests. So they should be able to direct you towards the right teams for those. It is a lot of running around, but Dr. LoSasso's office gives very detailed descriptions of exactly what they're looking for. And not once did somebody say, what are you talking about? So that was great. And of course, we arrived after for Connor prior to his surgery. And I remember looking at Georgia and I said, are you sure you have everything? Did we do it all right? And it was fine. So it was really thanks to Dr. LoSasso's team, and they made it really simple because we weren't necessarily dealing with specialists who had, they had heard of the Nuss procedure, but it was not something that they were doing pre-op for on a daily basis. So it actually was fine. And for the allergy testing, just a little side note, we ended up working with our dermatologist. And he ordered the metals because for some reason the two allergists that we talked to here said that wasn't something that they typically do. So
did you point out that both our kids were allergic to the metal?
Oh, yes, that's a good point. Thank you. We didn't mention that. Both our kids had possibly had metal allergies, and there's no point in fooling around with it. So they both were fitted for a titanium bar, and bars for Grace. So we did for Grace and Connor. I guess we had to fly out a little bit. Or Connor, maybe we went out earlier, but they both needed to be fitted for the titanium bar. And so that was a consideration, but it was fine. Check in with your dermatologist if your allergist says that they are not able to do that testing.
Okay. Thank you. Appreciate that.
We had a couple questions in chat from earlier today regarding over 35. Somebody said, I'm 63. Can you tell me what happens if we don't get it fixed at this point? We do have a lot of resources about that. Dr. LoSasso, you might want to chime in here as well. We will be having a webinar later on this year in the next couple of months, specifically for adults. But Dr. LoSasso, do you have anything you want to add to those questions in the chat?
Sure. Let's start with the question of the workup, because I think that's an excellent question. And just as Renee said, I think it depends on where you are living. Some very sophisticated medical communities can do the workup and do it expertly, and that can just be sent to me for my review, and that checks that box off completely, and I can base my opinion on information that is superb in that instance. If someone is in a less sophisticated medical community, then the option is always to come to New Jersey and to have the workup done by my team locally. That can be pre-arranged so that it's done in fairly short order within a matter of a few days. And then I can review those tests, and we can make the appropriate plans. So that's how I've always done the patient from a distance. Work with that individual family, make an assessment as to whether or not the workup can be done locally, and if not, coming to where I'm at and having it done by my team is always an option. For the patient who is further along in their life journey and come to me as an adult, we'll define that as over 21. Like I said, I've done patients in their 5th decade of life. I'm comfortable doing the older patient. Not every pediatric surgeon is. Because I was an early adopter of the procedure, a lot of adults were coming to me as a result of that. And my thought was, if not me, then who could address the needs of this older population? And so I jumped in with both feet and began to do the older patient. I came to learn very quickly that they present their own unique challenges, not only because they may have other medical conditions that need to be taken into consideration when one considers doing the operation, but the actual challenge anatomically for the surgeon is sometimes very, very significant because the chest is heavier, more rigid, and the patient has fully expressed the deformity as an adult because they've, gone through the growth phase of their lifetime. And so those additional challenges require additional expertise. And I think it is important that the adult who's considering having their pectus addressed surgically have to go to somebody who not only does the Nuss procedure, but does the Nuss procedure on adults and have done a lot of them. I repeat, a lot of them, because it's different than doing the young adult, the teenage. And so just because you've done that cohort of patient does not mean that you are instantaneously capable of doing the adult operation, because it's just different. So I'm able to do both types of patient, both age groups at the Valley Hospital. I enjoy doing both. They each have their own unique challenges that they present. And I'm hoping to do a webinar in the near term that addresses the special needs of the adult patient with regards to not only evaluation, but also treatment.
Dr. LoSasso, we have a question that came up via chat earlier. How long does the surgery take on average? And we're just going to assume that's day of surgery.
Yes, okay. That's a great question. And it really depends on the following factors. If the patient has a severe deformity and requires multiple implants, then it just simply takes longer. And so I would say it's anywhere from a 3-hour operation to an 8-hour operation, and anywhere in between, depending upon the specific circumstances of the patient. The question of whether or not multiple implants are necessary has to do with the assessment that the surgeon has to make intraoperatively as to whether or not a single implant achieves the objective, which is to lift the chest wall off the patient's heart. And if that can be accomplished with a single bar, then your work is done. If that has not been accomplished, then additional implants require additional time to prepare the implants and insert them, and then to secure them. And that just varies from case to case and patient to patient. But the broad answer to that question is anywhere from 3 to 8 hours.
Thank you, Dr. LoSasso. We have a question from Patty. Patty, if you want to unmute yourself and or turn on your video, go for it.
We've consulted with other surgeons, and some of them suggested using
Hi.
as pre.
Patty, we're having a hard time hearing you.
Oh, the video.
There we go.
No, they wouldn't.
So we consulted with other surgeons, and some of them suggested using the vacuum bell in the preoperative stage, as it could improve the results after surgery and ease the surgery as well. So what are your thoughts on that?
I think that's an excellent question. And my answer is that the vacuum bell can be of some benefit, especially with patients who have very severe deformities, to create some flexibility in the chest preoperatively, which is an advantage in the ultimate ease of achieving that that objective that I just described, which is to get the sunken chest off the heart. I don't think it's an absolute prerequisite. I don't suggest that a patient do it per se, but I have experienced in certain patients that have chosen to do it, that it has had some benefit with regards to the ease of achieving that ultimate outcome. I have been less impressed with the vacuum bell as a sole treatment modality for pectus excavatum. I think if you're very young and have a mild deformity, it can improve that functional and cosmetic outcome. But I don't think it is a definitive long-term solution to significant pectus excavatum, especially if you're a bit older and you have a moderate to severe deformity.
Thank you.
You're welcome.
Perfect. We have another question that was sent in via text message, actually two of them that are somewhat similar. It comes up quite often. How often did your pediatricians, this is aimed at the parents, say that it was purely cosmetic and that, you know, it wasn't that important? Obviously insurance, that comes up a lot as well. So double questions to parents. If it wasn't truly medically necessary, or you were told it wasn't truly medically necessary versus cosmetic, how often did that come up in each of your cases?
Well, I can speak to, you know, Julian was diagnosed as an infant, so we had many years of a conversation of whether it was just cosmetic, and that's pretty much what we were told. I think from a you know, I kind of found out after the fact that our pediatrician was somewhat uncomfortable with surgeries that he had heard of in the past, and this is an older gentleman that, you know, that he was not, he never really told us or educated us about what our options were. So he really focused on the cosmetic part of it. And I think his feeling was it's cosmetic till it's not. And we went in really thinking that this is mostly a cosmetic procedure. As far as all of the testing that you do, that's where I think you really start to find out what is really going on, you know, inside your child's body. And I know somebody had asked a question about Marfan. I had never heard of Marfan before, but our first appointment with Dr. LoSasso, my son has very long fingers. He's 14 years old and 6'2". My husband is 6'3" and also has pectus. My husband has mitral valve prolapse. We didn't know that Julian has a mild case of mitral valve prolapse, which we did find out, you know. So we in doing the testing, we started to find out that there was so much more going on beneath the surface, beneath the cosmetic story. Marfan was a whole new thing for me to Dr. Google about, and was definitely the scariest thing for me to start figuring out, like, what does that mean and what does that mean for his future? We don't, so he was tested, he has the mitral valve prolapse, he has the pectus, he has long limbs and long fingers, and so some features of Marfan. He did not have the aortic valve feature. He didn't have the issues with his eyes, which are indicative of Marfan. But because we haven't had genetic testing, it can't be 100% ruled out. So I think it's really not until you start having the testing done and find out, we found out that his heart was actually being shifted to the side, and that his lung capacity is at a very, very low normal range. So, you can hear that it's cosmetic until it's not, and then you start to find out more things. So.
This is Kim. I just wanted to touch on something that Heather mentioned about the doctor being, or a pediatrician being a little bit hesitant about Pectus. Something to know is that the Nuss procedure has been the golden standard for about 20 years, a little bit over 20 years now. Before that, it was the Ravitch procedure, which is a much more invasive procedure where they're making an incision in the center of the chest, and you're manipulating the structure of the chest around. It's a lot less predictable, a lot more intrusive. So if you are working with a pediatrician who was trained over 20 years ago, that might just be their perception of, this is how this surgery is treated. You don't want to do that. You don't want to exchange a dent for a big scar and risk that. So it's just something to keep in mind, as you're talking to, getting opinions of kind of how were they trained, when were they trained, and what, did they just hear about Pectus, or, did they really work with somebody who knows Pectus well? So.
I don't think that the pediatricians are trained. I think they just know there is a Pectus and you don't do anything about it. So I think you have to go to your pediatrician and say, I want to know more about it. And actually, we have an outstanding pediatrician who's not that old, but the first doctor we saw was one that does the Ravitch. So I don't think you can rely on your pediatrician.
I'm going to chime in here for just a second and say, I think what this conversation illustrates is just how important educating yourselves as medical consumers really is. And that the important thing that I would like to leave you with is the following. There is a cosmetic aspect to Pectus. However, that's only a very small part of the story. And if you understand that, then you can take any comment that anyone gives to you in that context and realize that the cosmetic aspect can have profound effects on the child, and that can never be denied or discounted. But that the real question is, what more does this deformity, what more role does this deformity play in the life of the patient? And that's what the specialist brings to the conversation. Because the specialist, first and foremost, knows this and knows how to sort of peel back the layers of the onion, get the information that's so vitally necessary for both you as the parent and the patient to know, so that the full impact of the condition can be completely understood. So it's unfortunate that there are primary care providers across multiple specialties who are less than fully informed. I've done my best and will continue to do what I can to educate my colleagues more broadly about the implications of having a chest wall deformity, but it's the very reason why I feel so passionately about going directly to the Pectus community and encouraging them to take control of the process, learn as much as you can about the condition and about your condition. And then I'm confident that you, as thoughtful, loving parents and as patients who have that information, will make the right decision for yourselves. So I think it's important not to rely solely on one individual opinion. Get multiple opinions and recommend to those people who come to you with some concern about Pectus to encourage them to do the same.
Do we have any more questions from anybody? Again, if you want to ask via chat, or if you use your cursor to hover over the bottom of your screen, there's a participants button and you can raise your hand and unmute yourself. We'll call on you. Or if the families have any statements, that would be great too. Wow, you guys all did such a great job.
Well,
I'd like to say something. You guys hear me?
Yes, we can.
Yes, we can hear you.
You know, it really wasn't an option for me. I'm older now, but you have a really hard, but my problem is I have a really hard time breathing. And, you know, I've had it checked. I go to specialists, and it's my chest is compressing against my lungs. It becomes very uncomfortable later in life as the years go by, more and more. So that's all I really wanted to point out. When you're young, a lot of times it's just, you know, I always heard it's cosmetic, and really there wasn't anything to do about it anyway back when I was a child. But now it just gets worse for breathing, where, you know, you're like panting just to go up there. I'm a person who exercises all my life, like a lot, you know, and still I lose my breath. It's just kind of debilitating. That's all. Just pointing that out.
Well, I would just say to you, John, that you're never too old to be evaluated for this condition. It's important, regardless of age, if you're having symptoms as you are describing, that you find someone that is experienced and committed to caring for this group of patients, and seek out some additional insight and information. So I would encourage you to find that person. And if I'm that person for you, then please reach out to me directly so that we can help to further define and evaluate all the issues that you may be experiencing. But I will echo this, that you can become more symptomatic as you age. That's not an uncommon story that I hear from patients who come to me in their 30s, 40s, and 50s, because the effect of the deformity then combines with the natural aging process to create further inefficiencies in the relationship between your heart principally and your lungs, such that aging and the deformity create a perfect storm that can make one much more symptomatic as you age. So your story is not uncommon, John, and I would just encourage you to seek out further information regarding your specific situation.
Thank you, Doctor.
We had 2 questions come up in chat. One person said to the families in general, if they want to reach out to them, how do they best get that contact information? How do they get in touch? So we highly encourage you to reach out to the office. Depending on who answers the phone, please just ask to speak to or leave a message for Dr. LoSasso's physician's assistant, Allison. If she's not available, she's often in surgery. Otherwise, you can definitely email through the website, nussprocedure.com. And at that point, we will put you in touch with whichever family you want to speak with, or any families, or answer any of your questions. A similar question, which some families here online might have more information on, but again, is a great thing to talk about. And we do plan to do a webinar about the workup pre-surgery. But what allergy tests should be done prior to the surgery? Which metals? Dr. LoSasso or any families, do you want to speak to that? Or is that a better question to just send in to Allison and Kim?
Well, I'll take that question because I think that's a more of a technical question. The most common, let's start with the most common component of stainless steel, which is the more standard implant that one would be allergic to is nickel. So nickel itself needs to be tested specifically for. But there are other less common components of stainless steel, and I won't get into, all of the various and sundry alloys that are part of stainless steel. But any allergist or dermatologist who does metal testing would know those specific alloys to test for. And if you as a family or patient have any specific questions about the thoroughness of the allergy testing you're being offered, please get in contact with me, and I will, or Allison will, vet the and confirm that the testing is adequate. But it's more than just nickel that needs to be tested, though nickel is the most common allergen within stainless steel that could cause a problem. And it's not an insignificant number of people who have a metal allergy. It's roughly 13 to 15% of the population has an allergy to metals without actually having had a known allergic reaction. So you can have a metal allergy and not know it until you're tested for it. So anyone with a significant allergy history or a history of atopic dermatitis, which is an allergic dermatitis, or of course anyone whose family has a member that has a true metal allergy should be tested. And any reaction to any of the allergens that you're tested for should immediately prompt a response in the surgeon to use a titanium bar. And titanium should also be tested for, though a titanium allergy is exceedingly rare. But that is the plan B for anyone with a metal allergy. It's to have a titanium bar like Connor and Grace have. That has to be predetermined, and then a specific implant needs to be arrived at, and that's a collaboration between myself and the manufacturer of the implant. That process is a very collaborative one where we both look at the chest wall imaging, and I've done the measurements, and then we agree on how best to shape the implant given the specific dimensions and challenges of the individual patient. So a titanium bar and the arrival at how that bar should be shaped is something that requires a lot of collaboration between the surgeon and the manufacturer. Just so that you know the magic behind the curtain when it comes to the needs that a patient with a metal allergy has.
Does anybody else have any more questions, or do the families have anything else they'd like to add tonight?
Well, I just want to thank everyone for their time and attention. I want to thank all the families once again for all the wonderful information that you shared. I'm sure it will be of benefit, not just to the 30-some participants in tonight's webinar, but online for the foreseeable future. So thank you all very, very much for your time and attention. And hopefully I'll see you again in a month or so when we do our next webinar. And as I think Kim had mentioned in the introduction, if there is a topic that you want us to address in future webinars, please send us an email or give the office a call. We're always anxious to address the educational needs of the community, and to know what those needs are requires some input from the community. So we would encourage you to let us know some of the things that you still have questions or concerns about, and we'll try to address that in future webinars. So once again, stay safe. Good evening to everyone, and thank you again from the bottom of my heart.
Thank you so much.
Ciao.
Thank you, Dr. LoSasso.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, doctor.
Thank you.
Have a good night, everyone.
Good night.
Thank you.